Okay. So, and stop with a clinical picture, and I must speak about more important and cramping pain. Cramping pain always you may see with patients. And next, in the acute adhesive intestinal obstruction, the nature of pain syndrome depends entirely on its types also. In patients with strangulate adhesive obstruction, typical pain occurs in the about 80% of cases. What? Question? No? No question. But more common in acute acute adhesive intestinal obstruction without strangulation. With acute adhesive intestinal obstruction without strangulation, cramping pain may be seen only in the 30% causes of patients. The characteristic things of acute intestinal obstruction, which occur in the 70 to 90% of causes, it's nausea and vomiting. Very often also you may see with clinical symptoms. In the first phase of disease, vomiting is of a reflex nature. Vomit is represented by gastric and duodenal contents. Without signs of stagnation. The pathogenic significance of vomiting and with staging the aggravation of water and electrolyte losses. Stool retention is not a permanent thing of acute intestinal obstruction and occur only in the 60 to 70% causes of patient with disease. Attention. At the same time, more often half of the causes against the background of stool retention, this change of gas persist single and sometimes repair stool is possible with small bowel obstruction. Fetus and form from intestinal container remain in the distal parts of the intestinal in relatation of the level of obstruction. Over time, the light intervals of shortness, the periods of contraction becomes longer. When due to the increase in intestinal paresis, the cramping pains are replaced by constant, dull, itching pain, as a rule without a distinct localization. Reflex vomiting stop, maybe. Next slide. The second stage. Are you see second clinical picture? So stages.
Doctor, also it's stay in the clinical picture.
Stages of intoxication, okay?
Yes.
Okay, good. So in these stages of intoxication, which in the sometimes called the father's imaginary well-being to the cessation of pain with initial unchanged general condition. At the behind of these stages, the patient actually feels somewhat better, but the picture some change. Bloating in the prognosis is prognosis. Progress bloatings, you may see increase size of tumor. Tumor is like a month. In the later stage of intoxication phase, vomiting appears again. However, now its cause is pronounced hyperextension of the proximal small intestinal with liquid contents. Fecal-like vomiting is called fecal vomit. The appearance of these symptoms in a patient is extremely unfavorable prognosis criteria signs. It indicates a significant overstretching and stagnate change in the most proximal parts of the small intestinal. At the second stage of a course of acute intestinal obstruction, non-specific signs of endotoxicate and hypovolemia are clearly manifested. And next stages, just секунду, так вот. Next stages, first stages of acute intestinal obstruction is characterized by development of diffuse peritonitis in the patient. The periods of development duration of the name phases of acute intestinal obstruction flow given by some authors are extremely conditioned. There are forms of ileus in which change in the intestinal grow gradually. With several days, subcutaneous forms of adhesive or colonic obstruction. And the manifestation of clinical begins, one might say, immediately from the stages of intoxication. In strangulate forms of ileus, the presence of necrotic intestine quickly and now lead to the development of peritonitis. When in the obstructive forms of acute intestinal obstruction, increasing endotoxicosis will be fatal for the patient, even in the absence of a peritoneal phenomenon. Next, physical examination. You may determine bloating. Bloating is a very common symptoms what occur in the 30-35% of causes. In obstructive and strangulate forms of ileus, swelling is more often localized in the area of the obstructor in about 60% of patients. A clean connect between the level of obstruction and the naturals of flatulence is more characterized of large bowel obstruction, which is explained by the limited mobility of colon. For adhesive obstruction processing without strangulation, for small bowel obstruction, and for dynamic forms of ileus, general abdominal distension, sometimes of very significant sites is more characteristic. Along with fleeting and important evidence in favor of acute intestinal obstruction will be visible intestinal peristalsis, its symptom of Schlench, both independent and induced by palpation or tapping on the anterior abdominal wall. So, symptom of Schlench, its obstruction will be visible intestinal peristalsis. Next, syndrome wall, visible abdominal asymmetry, visible peristalsis, palpable swollen bowel loops, and high tympanic on percussion are called wall syndrome. The pattern of abdominal is persist for a long time. You need the development of excessive flatulence or peritonitis. Next, you must do palpation. On palpation, it is necessary to access to consistency of abdominal wall, areas of local pain, tension of abdominal muscles, symptoms of peritoneal retention. It is important not to confuse the resistance of anterior abdominal wall over the swollen bowel loops and the tension when the peritoneum is irritated. Next splash noise. An important thing excessive by palpation is the splash noise. This symptom is detected with a slight lateral concussion of the abdominal wall. The emerging murmur can be localized or defined through the abdomen. The appearance of this phenomenon indicate the presence of the overstretching paretic loops filled with the liquid and gas. Next, you must continue physical examination and with percussion of abdominal with patient with acute intestinal obstruction. It has an uneven distribution of tympanitis characterized by a high sound with a metallic timbre over the swollen areas. When percussion with episymetral simultaneous with auscultation and can define the Kiewitz symptom. Kiewitz symptoms are percussion sound with a clean metallic tick. Next, dullness of percussion sound can be determined by tumor and inflammatory infiltrate, as well as in sloping place of the abdomen, areas of accumulation of peritoneum exudate, which is more typical for strangulate forms of obstruction. Intention with percussion more important for patient without obesity. If your patient has obesity, it's very difficult to determine with symptoms. But if your patient normal constipation, you may determine with typical symptoms. The auscultatory picture in the ears is rate poor and is characterized mainly by an increase in peristaltic noise in the ileus cry phase and away subsiding with the development of obstruction with the outcome in the tight science during the formation of intestinal paresis. With significant bloating, it's possible to determine the Lotisan symptoms, leasing through the abdominal wall of respiratory noises and heart sound, which normal do not pass in this way. This phenomenon is also known as Bell's symptoms. With auscultation is also possible to detect the nausea of feeling drop. It's a symptom of Spasokukotsky. A mandatory step in the examination of any patient admitted on an emergency basis to the surgical department, especially a patient with suspect acute intestinal obstruction, is digital examination of the rectum. In this case, sometimes the main cause of obstruction is tumor of the rectum, fecal obstruction. In addition, this study can determine the shaping of the anal sphincter and the balance of empty empire of the rectum, which like what symptoms of Abu Hospital. In the every my lessons I speak about these symptoms. Why is name of these symptoms of hospital? Because it's called in the symptoms of hospital localized in the town of St. Petersburg, and also maybe determined symptom Grekov, and also maybe determined symptom Hogenic. With intuitive of intestinal relaxation of the anal sphincter is now as Hirschsprung symptoms. Also maybe determined. Так, so next. Сейчас, секунду. Next slide, and next method, instrumental method, investigation of acute intestinal obstruction, and a more important method, it's method X-ray. X-ray is examination is mandatory in all patients with suspect of acute intestinal obstruction. At the first stages, in our wire X-ray of abdominal organs is performed. The picture is taken in a standing position, in a direct projection. In the course of a serious condition of patients, when they can't by put on his feet, it is permissible to perform the study lateral position, lie on his side. It is not recommended to examine the patient in a sitting position, since only the upper half of the abdomen cavity is usually visible. What you may see, the presence of horizontal fluid levels, Clover cups, Clover balls, and contour curing folds of the radiography, positive causes symptoms of fish skeleton, was scratching spring, is an indicible radiology things of acute intestinal obstruction. And are you see my cursor? Are you see my cursor? No? Are you see?
Yes.
Yes, okay, very well. On this picture you see cups, Clover cups, level of fluid, and also in this place, in this area where I am shower, you see fish skeleton, or as a word, stretching spring symptoms typical for acute intestinal obstruction, and also you may see dilatation size of with intestinal. So next, X-ray control of the pacing of barium suspension, Schwartz test. The patient is given 100 millimeters of liquid barium suspension per oz. A general picture of the abdominal cavity is taken after 2, 4, and 6 hours. When performing oral contrast and interpreting the data obtained, it is necessary to take into account the timing of the advancement of the contrast against through the intestinal. In a healthy person, the barium suspension drink per oz reach the circum in the free with half hours. The right band of the colon after 5 to 6 hours, the left band after 10, 12 hours, and in the rectum after 24 hours. Next, you can see X-ray picture of intestinal obstruction symptoms, fish skeleton or stretching spring, also in this picture, in this scan. If it's impossible to perform or contrast study, the so-called water test is used, which consists in taking a glass of cold water, after which an increase in the number of horizontal liquid levels can be determined by radiographic analysis. So next method, more rate, but sometimes maybe use ultrasound method. More informative attention, and I am repeat, more informative is X-ray method investigation and X-ray method with contrast. ultrasound graphy detect so-called intraluminal fluid deposition syndrome, maybe, which is defined in all patients with ileus. Liquid contain allows you to visible the intestinal, measure its diameter, wall thickness, aware of folds of the mucous membrane, excessive nature of peristalsis. Doppler ultrasound makes it possible to quantitatively excessive peristaltic activity of intestinal, to distinguish true peristalsis from the chaotic contraction of individual areas. Also, maybe use computer tomography, your favorite CT scan, in the diagnosis of intestinal obstruction. CT scan allows to reliable establish the present levels and severity of disease. The development of endoscopic research methods in emergency surgery has made it possible to use laparoscopy in the diagnostics, and during my lessons I am show video laparoscopic diagnostics acute intestinal obstruction. But attention, if you think about adhesive disease, the adhesive disease is contraindicated for laparoscopic investigation. So next question: treatment. Treatment of patient with acute adhesive intestinal obstruction begins with a trial of conservative therapy. The goal of this treatment is as follows: reduction of intoxication, normalization of activity of the cardiovascular system, correction of electrolytes imbalance, and elimination of dehydration. It's more important positions conservative treatment. Conservative therapy is based on the principles of drip and set. Treatment begins with the introduction of nasogastric tube for the compression and lavage of the upper part digestive tract, which reduces the intracavitary pressure in the intestine of absorption of toxic products. The scope of the therapeutic benefits include the following activities: gastric lavage and emptying, cleansing enemas, the introduction of hypertonic sodium chloride solutions. Maybe use potassium chloride solutions, 1500 milliliters. Upon injection solution of prozerins, it will stimulate peristaltics. Pituitrin maybe give, and attention, if you see stop moved, you don't use prozerin. For the same purpose, sertal is used in the form of injection intramuscular 10 millimeters, or in the form of tablets inside, use urotide prozerin calamine. In the event of ionic disturbance, infusion resort to hemodialysis, reupoleglucin, copolamine, Trental, drugs for eliminate metabolic acidosis. If necessary, transfuse dry plasma, polyamine, alvezine, together with them potassium preparation panangin are administered. Novocaine lumbal blockage is used mainly for functional and dynamic disorders and only one. In the severe attack, indicate the mechanical nature of the obstruction. The blockage should not be used. Next, you can refrain from the operation only in those cases when the in the fluence of the therapy, no more than 2, 3, 4 hours after admission. A significant and lasting improvement occurs. In the all other causes, surgical treatment is indicated. Sometimes it was noticed what the operation, the acute periods is always more dangerous and is accompanied by the high morbidity rate up to 13 and to 20%. Thus, the indication for surgical are determined by the types of adhesive obstruction. On an urgent basis, 2 to 4 hours after admission, patient with acute obstructive obstruction complicated by peritonitis and strangulate adhesive obstruction are operated on. Only operation, surgical treatment. With patient undergo intensive infusion therapy during the specific periods of time, which allows the patient to better under anesthetic and operational stress. Patient with chronic obstructive and recurrent adhesive obstruction are routinely operated on. Modern endotracheal multi-component anesthesia is the method of choice in the operation for adhesive disease. Good relaxation allows you to revise the abdominal cavity from one excision and separate the adhesion to reduce mechanical trauma to the peritoneum. From this position, the choice of the operating access becomes very important. A significant part of patients with adhesive intestinal obstruction is operated on more one answer of with anterior abdominal wall is distinguishable by postoperative scar. The foremost surgical considered the best approach to be a lower midline laparotomy, which can be explained up where is desired. Access through the old scar with its obligatory excision is from with formidable complication, opening the intestinal lumen, signs intestinal loops or amentum areas are often sold to postoperative scars. During operation in a patient with adhesive obstruction, regardless of its types, it is necessary to observe a number of methodological techniques, deviation from which leads to undesirable and severe complication. Unlike other operations, it's impossible to begin some revision of abdominal cavity without splitting the adhesions. When entering the abdominal cavity, the scar tissue of the active roses and eject scar altered areas of peritoneum are excited. You must remove with scar and cut with scar and adhesion. And very often gross change are not in the great amentum, therefore in the presence of acute or chronic omentis. Resection of altered amentum section is indicated up to is a complete remove. removal. And principles of surgical treatment. Surgical measure for adhesive obstruction depend on the nature of adhesion and the types of intestinal obstructions. The most common operating the separation of adhesions. Plan adhesion causing kinks, constriction, the formation of duct body, dissect, and push appear with stitching. The connective tissue codes are excised at the site of with attachment. The source surface on the intestinal and peritoneal side by imposing internal sutures on the intestinal wall in the transverse direction. Narrow defect in the peritoneal lines of the mesentery are peritonealized with interval sutures. The attachment points of the trunk are invaginate with four-string or Z-shaped sutures. In the presence of necrotical altered areas of intestinal loops, resection is performed according to the general rules in one volume or another with accompanied by restoring intestinal patches or forming a therapeutic stoma. With criteria adhesion what deform the bowel loops without establish the wall nutrition, the imposition by pars anastomosis is shown. More often between these loops of a small intestinal, less often between the section of the large intestinal. The surgery find himself in a difficult situation in the presence of a dense conglomerate mass of intestinal loops. It would be rational to impose a bypass, radical, optimal for the patient, resection of entire conglomerate with mass. When operating on a patient with adhesive intestinal obstruction, a number of measures must be observed to prevent the recurrence of adhesive formation. The excision of the anterior abdominal wall should be wide enough while the peritoneum should not be round grasped and part of the edge of the wound. Napkins inserted into the abdominal cavity should be now fixed to the peritoneum. The most difficult problems in the surgical treatment is recurrent adhesive intestinal obstruction, adhesive disease itself. An operation to prevent replace of adhesive disease was proposed novel. Incorrect. Sorry, just during my lecture, I'm change data noble, which described with operation. Sorry, only in this moment IMC with так и надо сохранить. Story. Okay, so yeah, you may see in this picture Operation Noble, and which is divided by application of the loops of the small intestinal with the deliberate creation of a control adhesion of intestinal is a preliminary place in a functionally advantageous position, what does not disturb the passage of the heme. From a wide enthusiasm of this operation, surgeons when switching to restrain a tube towards its sinks and rely anti-physiological and mechanical nature of idea itself. But we life in the surface of patient make the surgery is a last resort undertake the noble operation for patient intestinal replications. Technique of the operation is follow. Starting from the iliocecal angle, the loops of the small intestine are placed in a parallel vertical rows. The length of each row is about 20 centimeters, and the peritoneal sheets were sewn together with a continuous sutures. With the same thought, a continuous gray cellulose sutures is used to sew the contacting intestinal walls along the mesenteric edge. Unfortunately, Noble's operations is fraught with severe, immediately bad results. Mortality is about 8%. And the replace of this disease are not in the 20% of causes. Next types, just a minute. Paralytic intestinal obstruction. The cause of paralytic intestinal obstruction is a convention divided into 4 stages. The first stages is the phase of complex respiratory disorders. Clinical, it is manifested by mild bloating and weakening of peristaltic murmurs, and patient's conditions remain satisfactory. The second stage is the phase of subcompensatory disorders. It's characterized by significant bloating, symptoms of endogenic intoxication with phase peristaltic sounds of the intestine are almost not heard. Patients are worried about constant belching and nausea. And next stages, third stages in the phase of the compensated disorders, at the same time, a typical picture of a functional develops intestinal weakness, abdominal distension, symptoms of peritoneal irritations, and during X-ray examination of a small and large intestinal, there is multiple Clover cups. And last stages, fourth stages, in the phase of complete gastrointestinal paralysis, with corresponds to the most severe stages of diffuse peritonitis. Here, in addition to the complete disturbance of the intestinal motors activity, all body functions are suppressed, severe intoxication develops, vomiting is not, and other clinical symptoms presence. At these stages, despite all the measure taken, it's often not possible to restore the intestinal motors function. This can be seen from the data present. Paralytic intestinal obstruction develops as a result of a violation of the regulatory function of a neuroendocrine system. The action of the toxic substance produced during the inflammatory process on the neuromuscular apparatus, and as well as a result of impaired blood circulation in the intestinal wall, oxygen starvation reasons, and metabolic disorders. You see. Treatment of paralytic intestinal obstruction. Timely treatment of benign paralytic intestinal obstruction is important not only because the development dynamical intestinal obstruction poses a serious danger to the patient, It is especially dangerous of certain anastomosis, or sutures are applied to walls of a digestive tract, overstretching and atony of the intestinal wall can contribute to the occurrence of suturous fissures due to mechanical stretching and trauma to the sutures lined with gases and intestinal contents, as well as impairment of the healing of the anastomosis. The introduction of probe into the gastrointestinal tract is used for aspiration of contents and decompression. The probe is passed into the small intestinal through the nasopharynx, gastrostomy, intrastomy, and cecostomy. Continuous drainage of intestinal, also of evacuation of toxic contents and provide repair decompression, regardless of the timing of the recovery of peristalsis. It was sometimes the general condition of patients improve pains, nausea, and vomiting disappear. Stimulate therapy is also used. A good effect is given by calcium pantotrental or chlorpromazine. 15 minutes after the administration of chlorpromazine, a cleansing enema is prescribed. The use of this therapy makes it possible to achieve the restoration and of peristalsis even in elderly patients. If ineffective with methods, it's necessary to more activity stimulate peristalsis with the help of chlorinsterase inhibitor, very often use prozerins, and also maybe use choline mimetics, oxalidine, for example. Recently, in the complex treatment of paralytic intestinal obstruction, long-term epidural anesthesia has been used, especially for compensation and subcompensation disorders of intestinal motor function. The introduction of analgesic into the epidural space release pains, imminent paralytic intestinal obstruction, blocking the corresponding nervous ganglia. However, with steadily disordered blood pressure, despite the normal initial values of the volume of circulation blood. Next, spastic intestinal obstruction. Spastic intestinal obstruction is a relative rare types of dynamic intestinal obstruction. In isolation, it is extremely rare. Therefore, particle values is small. Usually, it has the characteristic of spastic paralytic intestinal obstruction. With spastic intestinal obstruction, the cessation of the advancement of intestinal contents is due to the occurrence of a persistent spasm of the muscular layers of the intestinal walls. More often reasons may be next: irritation of the intestine with roof of food, forget bodies, helminths, intoxications, disease of certain nervous system. The duration of spasm can be different from several minutes by several hours. Treatment, only conservative, only conservative. In most cases, after the application of head, lumbar novocaine blockade, physiotherapy procedure, antispasmodics, enemas, and it is possible to relieve the spasm, stop the attack in all the causes after treatment of the underlying disease. The phenomenon of spastic intestinal obstruction go over on their own. Invagination is one of the bases of mechanical mixed intestinal obstruction. You may see this condition in the 3 to 4% causes. It's all causes intestinal obstruction. It occurs as a result of the introduction of the adult segments of the intestinal into the abducting one. It is explained by virtue of the peristalsis of individual segments of the intestinal. The spasmodic section of the intestinal is introduced into the distal locate section of the intestinal, which has a normal tone. Impaired motor function can manifest itself as paresis of the segment when approximately locate section of the intestinal is introduced into it. Sometimes both of these processes are observed simultaneously. One area is paralytically expand the other, locate nearly. It's spastically narrowed. Invagination is more often descending when the proximal segment is introduced in the distal and less often extending when the distal is introduced into the proximal. The causes of invagination can be inflammatory change in the intestinal, in the appendix, and in the mesentery of intestinal are present of ulcer scar. Invagination is more common in children. Clinically, in the most causes, the main things of acute intestinal obstruction are observed: abdominal pain, nausea, vomiting, stool, and gas retention. The stool contain blood with mucus, respectively jelly. During palpation in the abdomen is determined by the elastic consistent, something like mobile tumor. After palpation, the pain increase due to increased peristaltics. Its symptom ruchsa. Treatment with conditions. In the presence of small colonic or colonic invagination with disease periods of no more 24 hours, invaginate can be tried to strangulate. Under X-ray control with enema, the barrier suspension is injection, and the exact localization of the invaginate is determined. The pressure is increased and the invaginate is palpated by squeezing it out in the retrograde direction. If the invaginate can't by straightening, the patient is operated on. During the operation, you should also try to strangulate in the invaginate by squeezing it out in the proximal direction. In no cause should not try to designate the intestinal by traction is also the longitudinal axis. If all manipulations are unsuccessful, resection of the invaginate is performed. Determination of intestinal validity. Many times I'm repeat, but also today I'm also repeat with indication validity of intestinal, loops of intestinal. Diet or life with intestinal. Curta method. First, determination of color loops of intestinal. Next, present or absent peristalsis. Moved. Next, pulsation of a mesentery vessels. Next, dry and dull serous membrane of intestinal. And last, test with novocaine. With understable subject has allowed many surgeons to stop at the resection of the proximal intestinal 40 centimeters long from the pathological zones and 20 centimeters of the distal intestine. You must determine demarcation line and next measure with area with long. However, the color of intestine can reliably distinguish only on almost normal intestine from the clean, non-velvety one. Peristalsis can be observed for a long time, even after necrosis of a mucous layer, and may be absent in a velvety intestine. In this case, due to the lack of oxygen supply, abrupt construction of intestine may occur, which mistakenly regards as peristaltic. Pulsation in the vessels of the mesentery can persist in the presence of the severe circulation disorder directly in the intestinal wall. Curta methods can be supplemented in the following way. If there are doubts about the validity of intestinal when methods of its restoration are used, the power loops can be lined with napkins with hot saline solutions, and 0.25% novocaine solution is injected into the mesentery. I hope you remember this information. And principles of resection of necrotic area of bowel. Also, you must know. Resection of the proximal intestinal, 40 centimeters minimum, maybe more, but minimum 40 centimeters long from the pathological zone, demarcation line, and 20 centimeters in the distal tension. Today, it's all information when you, which I speak.